All righty.
Okay. So shall we start?
Yeah, just the volume, your volume. Oh, yeah. Okay. Yeah. This is the second part of the clinical research design. Part two, examples from the medical literature. We'll start with recapping yesterday's lecture. And tomorrow, apparently, you have a workshop which will focus on the same material but in more detail, in a more expanded sort of way. So go ahead, Rachel.
Okay. So from picking up from last night, we talked
No, your
about.
volume is low.
Okay. Picking up from last night, we talked about design of clinical research and some considerations that we should be making when we're reading the literature and when we're designing studies. The scientific process goes something like this. We all are clinicians. We work with patients. We make many, many observations. And over time, we develop theories that grow out of our clinical experience. From these theories, we generate ideas that become hypotheses. And from those hypotheses, we generate research questions. And from the research questions, we design research studies to test these hypotheses. To do this, we collect data from patients, analyze the data, write this up in some format, whether it be an abstract or a manuscript, and we share our findings in some venue or other. We looked last time at the basic elements and sequence of a study protocol. From the research question, which basically asks what the study is hoping to answer, the background and significance, asking why this is important, the design, how the study will be structured, including the time frame, looking forward, looking backwards, the epidemiologic approach, whether we're doing an experiment or whether we're sitting back and observing. We're going to look at who the subjects are, how we select subjects, and the variables we're going to measure, the kinds of variables we'll measure. We talked about predictor variables, ones that we choose, that we can manipulate, that we think may have an impact on our outcome. And we also talked about confounders, that is, confusing variables that may get in the way by either hiding a relationship that's true an outcome or that may suggest a false one. We talked also about statistical issues, hypotheses, how to structure hypothetical questions with a null and alternative hypothesis, and how we used the hypothetical questions to format our sample size and decide how many subjects we're going to need in order to answer our question, and a few of the statistical methods that we use to decide whether we have successfully rejected our null hypothesis. So again, just pick kind of diagrammatically the basic study designs. We either do an experiment where we do something for or to a patient, whether that be give them a particular drug or a different intervention, or compare two different drugs or interventions, or we observe. We observe patients and make comparisons, or we describe, and we do that by looking at people over time, or by doing so at a single point in time, or by looking backwards. The randomized control trial versus observational studies was something we talked about last time. The randomized control trial, which we abbreviate as RCT, can give definitive answers on important clinical questions and can actually relate cause and effect. And the reason for that is we've assigned the intervention to people at random. So there should be no difference between the characteristics of the patients who did or did not get the intervention. That's very important. Observational studies merely describe associations. Observational studies can be very valuable, but they can also be wrong. And meta-analysis, which combine the results of observational studies can also be wrong. We showed you last night about the hormone replacement studies and how a very, very different implication was arrived at when a randomized trial was actually done. So the bottom line is that confounders, or these confusing variables that we have to look for, can be minimized in observational studies, but they can never fully be eliminated in any of these non-randomized studies. So we must interpret findings from observational studies with a fair degree of caution and skepticism. To diagram this, a confounder should have an independent relationship of its own, both with your predictor variable and with your outcome variable. So the fact that it has these independent relationships is what can cause this confusion. So we must look for these possible variables in an observational study, and doing this means you'll know your subject very well before you actually do the study. You'll know what the nuances are, what the other factors might be, and you will go and look for them and try to, as best you can, to control for them. We looked last night at an example of possible confounding. It would be trying to evaluate whether cigarette smoking has any impact on development of ischemic heart disease or coronary heart disease, CHD. We sort of surmise that smoking and alcohol consumption may be highly correlated. At least in our society, they are very highly correlated with one another. And it's possible that cigarette smoking may actually mediate coronary heart disease rather than alcohol consumption. So in this case, if we're trying to study the impact of alcohol on development of coronary heart disease, we must take smoking into consideration because it is associated with both our predictor and with our outcome. Another example in the same sort of vein would be to ask the question whether drinking coffee is associated with development of heart disease. And this has actually been asked by many investigators. I think if you ask that question, you have to also consider the fact that coffee drinking could be common among smokers. In fact, many people smoke when they drink coffee. It's known that smoking is, by biological animal studies and many epidemiological studies, is known to be associated with development of cardiovascular disease. So it's likely to be a confounder if we're trying to look at the impact of coffee drinking on development of ischemic heart disease. So a confounder variable, just to recap, is a condition that has a relationship of its own, both with the predictor and the outcome variables that you've chosen to study. So what it can do is it can hide a true relationship of cause and effect that might exist between your predictor and outcome variables. On the other hand, it can also suggest that there's a false relationship of cause and effect between two variables when in fact there isn't. And we'll talk about we talked last night about some examples of both. How do we state hypotheses in studies? We must state them in advance of when we actually start collecting the data and doing the study. And the research question must be phrased so that we list the main elements of the study as outlined in the design, including the predictor and outcome variables we're interested in, the study subjects, who they are, where we're studying them, and when. And the basis for calculating the statistical significance and sample size needed for the study will be given in the hypothesis. The statistical significance is going to be the probability that you're going to accept that your findings that you've made are going to have been found not by a real association, but by random chance alone. There's always a chance that that's going to be true, and we try to make that number small. So again, the two forms of the question, the null hypothesis would say there's no association between alcohol use and development of liver cancer among 50 to 80-year-old men in Tasmania, where the alternative hypothesis would say there is an association between alcohol use and liver cancer among 50 to 80-year-old Tasmanian men. This alternative hypothesis can be stated as a one-sided or two-sided statement. A one-sided statement actually indicates the direction that something will differ. For example, it will say the alcohol use increases the liver cancer. A two-sided alternative hypothesis does not indicate the direction of the difference. all it will do is say there is an association between alcohol and development of cancer. It could be positively or negatively correlated. So a two-sided statement leaves one's mind open to saying, hey, it could be different, but maybe it'll make it worse, maybe it'll make it better, maybe it's protective. So the two-sided statement must always be used for sample size calculation, because unless we know the answer, we have to leave our mind open to the possibility that the association may be opposite of what we think it is. We talked last night about the humorous example of trying to figure out why your socks are missing. One of your socks is always missing from the laundry. The null hypothesis would be aliens who are not to blame. There is some other explanation for your socks being missing. The alternative hypothesis was that extraterrestrial aliens actually have invaded your house to steal your socks. So there are two from that types of systematic errors that we could make when we do the study. One would be to falsely reject the null hypothesis. So this would be where in a situation where the null hypothesis is true. In other words, there is no association between your predictor and outcome. So your initial null hypothesis was true, but you have, based upon your decision making in the study, you have rejected the null hypothesis in favor of the alternative. This incorrect rejection of the null hypothesis is called a type 1 error, and you, for example, would have concluded that the aliens took your socks. And this is a type of error that is very damaging to make, particularly when accepting the alternative hypothesis might mean giving people treatment that would either not help them or might actually hurt them. If the relationship between the variables is actually not there, in other words, if the null hypothesis is true, if the null hypothesis is false and there is a relationship between the variables, but you fail to reject the null hypothesis, you cannot find the association. This is called a type 2 error, and you fail to reject the null hypothesis when in fact the null hypothesis is false. An example would be that you conclude that aspirin is no better than placebo in preventing thrombosis in a vascular stent. So we talked about last time what kind of measurement we're making. There are measurements that are sort of by category. They can be binary or dichotomous and can be yes or no. Examples being whether a patient lived or died, had an outcome like a heart attack or didn't. And we tend to express those as counts or proportions. There are named categories, which we call nominal. These are not in any specific order, but they are there are often more than one. They could be ABO, blood group, they can be gender, and those again are expressed as counts or proportions. They're ordered categories, which are in a certain sequence, but the intervals are not meaningful and identical. So ASA classification, there would be pain scores. There are low or medium or high complexity. All of those things have an order to them, but they don't have defined meaningful intervals between them. The other end of the scale is called a continuous variable, and these are ranked values with quantifiable intervals. Examples being body mass index, blood pressure, heart rate, troponin, glomerular filtration rate, hematocrit. So there are many biological examples of variables with that are continuous in nature, and we typically express these in terms of their means and their standard deviations. So how do we increase the precision of a measurement? It has many advantages. One is to standardize the method that we're going to measure it. So that means in your protocol, you describe in detail how the measurements are made, and that then you assure that all of the collectors of data, and that can be your medical students or your research assistants or whoever your team is, are all doing the measurement the same way. Another way to enhance precision is to refine whatever the instrument is or tool is that you are using to make the measurement. So this could be an electronic instrument, it could be a questionnaire, etc. So you try to, in the case of an electronic instrument, you try to make sure it's well calibrated, you make sure the questionnaire is easy to understand and answered by your subjects. Another option is to repeat the measurement if it makes sense to do this and take the average of 2 or more values. So all of these are certain ways that people sometimes enhance the precision of a measurement. And then there's accuracy. Accuracy is a little bit different than precision. Precision narrows down the value to being a very reproducible value. Accuracy actually means the value is correct. So ways of enhancing accuracy, one is to enhance the precision, like we just talked about. But another important thing is to try as best you can to minimize the bias of the measurement. There are several forms of bias. 3 important forms are going to be bias from the observer, and that could be you or that could be one of your colleagues. So to minimize observer bias, we go through very defined training on how we make a measurement and then blinding ourselves and our team members to the assignment of the individual patient or subject in order to minimize any kind of bias we may introduce by knowing, well, the patient is getting the real drug or is getting the placebo, so we have to really not know that. Another is instrument bias. Sometimes we'll have an instrument that will tend to err on one side or the other. So again, calibration of the instrument also improves the accuracy. And then also blinding the subject. So don't let the subject know that she or he is getting the drug or the placebo, because often this will then influence the reported findings. The patient, sometimes your findings may depend on what a patient will say. For example, will give a pain score, and if a patient thinks that she or he is not getting the drug, she or he may report a higher pain score. Or conversely, if a patient thinks that she or he is getting a drug, there may be a placebo effect, and that patient may report a lower pain score. So it's very important to blind the subject as well. So with dichotomous or yes-no measurements, the gold standards for accuracy are using a test that has high sensitivity and high specificity. So hypothesis testing, we're going to say what kind of statistical test do we need to use to both calculate a sample size and then in turn determine whether the null hypothesis can be rejected. And here we've listed several predictor variables, that is variables that we think may impact the outcome, whether if they're binary or dichotomous, meaning yes or no. They may be continuous or in a continuous numerical, or there may be multiple predictors, or they may be a mixture of them. The outcome variables similarly could be dichotomous, or they can be continuous. So if we're measuring, for example, we'll go through several examples of the combination of these. What statistical test would you use? And here's an example. A question would be, how long does it take from the discontinuation of sevoflurane or desflurane until a patient first responds to command? So what kind of predictor and what kind of outcome would you have? So the predictor variable is what? Is going to be the anesthetic given. It's going to be sevoflurane or desflurane. So that's going to be a dichotomous predictor. And it's a nominal dichotomous predictor. What's your outcome variable? Well, that's going to be time, and time in seconds is going to be a continuous measurement. So if we go back to our table here, we've got a dichotomous predictor, we've got a continuous outcome variable, and we look where they're going to be a comparison of means, and we're going to use a t-test. Now, we won't go into detail about what a t-test is, but it's really important to have an idea of what tests you would use to do this. Here's another example of a question. How does assignment to a long-acting beta blocker compared to assignment to placebo impact the risk of heart attack and 30-day mortality after surgery? So what's our predictor variable? It's going to be perioperative beta blocker or placebo. And what kind of measurement this is, it's a dichotomous measurement. The outcome variable, what is that? Whether you have an MI within 30 or you die, that's going to be a dichotomous variable. So we go back to our table again, and impact of beta blocker versus placebo on these outcomes at 30 days in a high-risk population. The predictor is dichotomous. The outcome is dichotomous. So we're comparing proportions, and we would use a chi-square test. Another would be, what are the impact of the MAC hours, body mass index of the patient, and the assigned anesthetic? So all three things, what are the impact of all of those things on the time from anesthetic discontinuation to the first indication of airway reflex recovery? So this would be the ability to swallow and guard the airway and prevent aspiration in the event of vomiting. So question, what are the predictor variables? They are MAC hours, body mass index, and anesthetic. So there are three predictors. What kinds of measurements are these? There are multiple. There are continuous variables, and those would be the MAC hours and the body mass index. And there's a categorical or nominal one, and that is the anesthetic assignment. It's going to be desflurane or sevoflurane. What is the outcome? It's going to be time, and time is going to be a continuous variable. So we go back to our table here. In this case, our predictors are multiple and mixed. Our outcome is continuous, and we would use a linear regression to determine whether this is going to be, whether we can reject a null hypothesis here, stating that these factors will have an impact on this time. So here's the results of the multiple linear regression. And just to not to belabor this, but we can see that the impact of MAC hours here has a coefficient of 150. So we will go into in greater detail in a few minutes what all of this means, but what we can say is that this is the slope of a line, and the slope is, this value says 150 with a p-value of 0. What this would translate to is that for every additional MAC hour of anesthesia, there's 150-second greater time needed to recover protective airway reflexes. So this kind of information can tell you a lot about a particular model, and it's doing this while it's also considering the anesthetic given and the body mass index of the patient. We'll talk about this study in greater detail in a few minutes. So what we'll do first, though, is take a step back and talk about what some common measures of association are. There are probability, which is also described as risk. There are odds, which we talk about, particularly when we talk about gambling and betting. There are relative risks, which compare two different risks. There are odds ratios, and there are correlations. So talking first about probability. Probability has a range between 0 and 1, and this is really a proportion, and it's a proportion of times you would expect to see a binary outcome per number of total events. So an example would be when you toss a coin. Let's say you toss the coin 100 times, and suppose you measured that it landed one of its sides, which you call tails up 50 times. That would translate to a probability for tails up of 50 over 100, or 1 in 2, or 0.5. And stated in normal phraseology, we would say that there's a 50% probability of tails. And this is used, probabilities are used frequently in descriptive studies. Odds are a little bit different, and it's confusing. The odds are actually...
Rachel, can I
Yes.
intervene? Can I intervene for a second? I think I translated like 2 slides back. I translated the terms and stuff. So I don't know. Do you have the last? Do you have the last version of the presentation that I returned to you?
I don't know what happened here. Yeah.
I don't see the Arabic translations. And, can you just check? We'll take a couple minutes, just a break to look at this. I think that I'm pretty sure that 2 slides back when you had all the
Yeah, I don't Yeah, let me, do you want to take a break now or take a break? You want to go through odds and probability, then take a break?
Well, the only problem is that we had. Can you just fast forward through this? Just go ahead and fast forward through this just a little bit so we can see if I'm a little bit confused here. Um, are you there?
Yeah.
Oh, um, because I'm pretty sure yeah, like I translated the what's heads and tails, and I translated the different definitions of relative risk, and a couple slides back, and I don't see any of that here, and I'm just worried. Is there like when you move forward to the regression, linear and logistical regression, do we have
Do you want to type it in the chat? Because I think that may be a different, maybe, let me see if I can,
no? Oh,
find,
well, I can't type fast enough because I have to hunt and peck because I don't have an actual keyboard. I have to bring up a keyboard and a screen and click.
take a break. Let's take a break then.
Okay, yeah. Let's if you go to your email,
Yeah. Let's take a break and then we can talk about this.
okay. Are you and I still talking about it, or you want to take a break? Oh, yeah. Get the the last email I sent you should have the translated version, quote unquote. Yeah, just
So,
take your time. Take your time. No big deal. It's just that it'd be such a shame, but it's not the end of the world. But it'd be fun. It'd be nice. I'll be right back, huh? Hold on.
okay. Yes. Yeah, the problem is that these weren't renamed. I think that's rats. That's the problem. Crap. I can't tell one from the other now. That is a problem. Let me see. That's weird. This is. Hmm. No, that's strange. I don't have it. Hmm, that's bizarre. Okay, that's not going to be it. Well, last one the emailed was not the one. Okay, part one. Nope, part one. Nope. That's weird. Right.
Okay, I'm back.
Yeah, I think it's weird because the one in our last email is the one I'm using, and for some reason the translations were not on there.
Oh,
It's
really?
bizarre. Yeah.
Okay,
So let me go. I have a different folder where it might be. I might be able to put some of these slides back up.
either
Um,
that or I'll look for mine too, by the way.
that's weird. That is weird.
Yeah, this real. Let's see.
Really
What
odd.
are we doing here? Um, try my finders.
Yeah, I don't know what. That's very strange that they kind of went. Because I remember seeing them.
Yeah, I know. I may have. Could I have
Watch them.
possibly put it on the? on the desktop. And
Which,
I should
which
put these stupid things on the desktop. I try to get too fancy by putting them in folders and then okay.
all right. I don't even know.
Now,
I'm
I
just
tell you what. Now, better yet. No, it's not a download. Of course not. It wouldn't be a. Yeah, it might be a download. Might be a download. Yeah. Let me try this.
I don't know what that's bizarre that they
No, no, no. It's
yeah,
got it. I've got it. So if I've got it, then
there's something strange that happened when I saved the presentation, and that is that sometimes the text gets scrambled, and the English text gets put in reverse order.
oh yeah, that's the
By reformatting them, it went away. It's bizarre.
yeah. Okay, how's medical knowledge generated? Hold on, I've got the presentation here that I. What is this? Oh, that's you. Those multiple slides are yours.
What are we talking about?
What I'm looking at now, this uh, 4 slides abreast. Is that your screen?
No, I don't think so.
No, no, it's not, it's mine. No, it's mine. Hold on, hold on, hold on. Yeah, here. That's not the one. I think I shoot. Okay, hold on, girl. I think I may have it may be me that screwed it up. Hold on. Mhm. Let me open this one. Mhm. 2 types of systematic errors. Here it is. I got it. Okay. Here's what I'm gonna do. Here's what I'm gonna do. I'm gonna email it to you right now. Okay.
Okay,
Alrighty. So
maybe tough.
2.22 hyphen 2 PPT.
Let's rename it.
I'm sorry.
We should rename it.
Rename it.
Yeah.
Okay. Um, save as.
Yeah. Just call it something else.
Yeah. What do you want to call it? Uh, Rachel research final version maybe.
No, never call something final because there'll be another
Okay.
version.
Yeah. Yeah. All right.
Delete it.
So Rachel research uh, 2 or dash 2 with Arabic.
Okay.
Yeah. And format, and we'll save it in the downloads. That's fine. Okay. Now let me, as soon as it's down, okay, we're done now. I am gonna go ahead and email it to you very quickly.
Okay.
Here it is. Okay, I'm about to choose it, and it is
ايش شغالين احنا
uploading. No, it's still uploading.
اتش بلس
Okay, let's see. Okay, I'm about to send it. Okay, it went, Rachel. Rachel.
Yeah.
Yeah, it's should be on its way to you.
يعني انت تقدري لها هاي تاكلك طلع
Got it.
You got it?
Okay. Got it. Yeah.
Okay. So maybe we can go back to the slide with the definitions of relative risk and the probability and such.
Yeah. It's still downloading on my screen.
Oh,
It's
okay.
not super fast. Okay. Yeah, I didn't. All right, there it is. Okay, let's take a few. Let's check out the ones that we need. Okay. All right.
اصبروا معانا شباب حصل
Okay.
خطأ هيك ما فيش الترجمة فاستعدنا الترجمة راح نبلش كمان دقيقة ها راح نعاود نبلش كمان دقيقة.
Oh boy, there's a lot of stuff here.
Oh, you mean I added a lot of Arabic stuff to the?
Yeah, there's a lot. Well, that's okay. It's good.
No, that's okay. You know, because, yeah, especially with the regression and stuff, I have one slide that we can just flash at them and leave it for a couple of minutes just so people can read it and understand in Arabic and then move on. It's really it's a lot easier.
Yeah.
On everybody's mental health.
Yeah, for sure. Okay, so let's see, linear. Let's do that. Okay, I'm just trying to, for sure. All right. Because I put some extra things in here that I think make it more understandable.
Oh, jeez.
Typically, you know what I mean? So there is that also.
Well,
there's that.
Can you have both?
And I didn't realize I was doing that with
Yeah, with the
it's okay. I got them.
Yeah, you can toggle between two presentations.
Yeah, we're fine. We're gonna be fine. Yeah, I got it. I think we got it.
Okay.
I think we got it. Yeah. Okay. So let's go back and
we need the presentation.
Let me show my screen. Okay. So let me do that. Do you see the screen now? Okay. All right. Let me see if we can. This is going to be better. Yeah. For sure.
Yeah.
Okay. So let's go back. Okay, so
Maximize your.
probability. Are you guys? Shall we resume?
Yeah, you want to go back to just the definitions, a couple slides back, the definitions
Yeah.
of probability and such,
Yeah.
just so people realize one more. There we go. Okay.
Measures of association. Probability is risk, odds, relative risk, the ratio of odds, and the correlation. Probability is something that ranges between 0 and 1. Basically, it's the proportion of times you. Hello?
Hello?
It's the proportion of times that you can expect to see a binary outcome per total number of events. So the example would be a coin. In 100 tosses of a coin, suppose you measured it landing tails up or a certain side up 50 times. That would mean that the probability of tails up would be 50 divided by 100, 1 and 2, or 0.5, depending how you want to describe it. And in words, we say there's a 50% probability of tails. And this is something that we often will use in a descriptive manner or in a descriptive study. Now, odds are a little bit different. Odds are the probability of an event occurring versus not occurring. So this is actually the probability divided by the inverse of the probability. So what are the odds of getting a tails flipping a coin? It will be the probability of tails divided by 1 minus the probability of tails. And stated in another way, it would be 0.5 divided by 1 minus 0.5, which is 1. So we say in words, the odds of flipping a coin and getting tails is 1 to 1, or is 1. So an example to illustrate this is if we compare probability.
Can you repeat this, the last couple of slides, just for, please go back.
No problem.
Probably, yeah.
No problem.
Yeah, there we go. Okay, thank you very much.
Probability is something that ranges between 0 and 1, and it's a proportion, and it's the proportion of times you would expect to see one of two outcomes per total number of events. An example would be the number of times a coin inside when you toss the coin. So if you toss the coin 100 times, and let's suppose you measured it landing with its tail side up 50 times, we want to know how to explain the probability of getting tails up. So we would say the probability of tails is 50 in 100, or 1 in 2, or it's 0.5. And we would say there's a 50% probability of that coin landing on tails. Okay. Odds, on the other hand, are different. Instead of being the probability of an event divided by all of the tries, you're going to have the probability of the event occurring versus it not occurring. So you're going to consider the probability of tails divided by the probability of it not being tails. So what are the odds you will get tails when you flip a coin? It's going to be the probability of tails divided by 1 minus the probability of tails. So in this case, it's going to be 0.5 divided by 1 minus 0.5, or equals 1. So the odds of getting tails in this coin toss are going to be 1 to 1, or in other words, 1. The probability was 0.5. The odds are 1 because we're measuring something different. Probability, recall, was measuring the number of times it landed tails divided by all the times you tried it. So that's a probability. It's a proportion. The odds are going to be the probability of the event occurring versus versus the probability of the other eventuality of it not occurring. So here's an example that makes it a little bit easier to understand. Suppose you have a surgeon, we'll call him Dr. Zippy, and he operates on people's spines. And you did a descriptive study and found out that 1 in 4 of his patients require a transfusion during spine surgery. So what's the probability of needing a transfusion if 1 in 4 patients requires a transfusion? It's going to be 1 in 4. 1 transfusion in every 4 cases. So that's going to be 0.25. On the other hand, what are the odds? The odds are going to be the probability of needing a transfusion divided by the probability of not needing a transfusion. So that'll be 1 here in 3. So you can see this is like a pie divided into 4 pieces. It's going to be 1 in 3 or 0.33. So odds denote a ratio of probability to its complement or its inverse. So let's consider 2 different experiments in scenarios and decide what we're actually looking for. The first scenario would ask the question, does giving a patient a certain drug X, and we'll call it X, does that influence an outcome we'll call Y? In order to do this, we have got to know the sort of the population baseline risk. So we would structure this question in a randomized controlled trial or in a large cohort study. And types of studies include drug versus a placebo, comparing 2 drugs, so drug A versus drug B, or an intervention versus giving standard care. So that's first scenario. A second scenario would be one where we ask, what are the odds of an exposure to a predictor variable if we have a certain number of people with a certain outcome we'll call Z. So this would be a case where the entire population risk is not known. And these are, if this sounds familiar, this is what you'd see in case control studies. Confounding is likely to occur without adjustment for other factors that might independently affect this, by the way. So in scenario 1, you would use the relative risk. It's a ratio of probability of an outcome with or without the exposure you're interested in. And confounding here is minimized by the randomization and the use of a large sample size. So that's where you would use your relative risk. How do we calculate the relative risk? It's we make a 2-by-2 table where we have on the top here, you got the outcome yes, or you got the outcome no. You had the exposure, the risk factor, whatever that was, yes or no. And we're going to say, you know, the relative risk is going to be the probability of an outcome with an exposure divided by the probability of an outcome without the exposure. So you can see that here's the exposure here is you can see it along the going from left to right, and you would divide A by A plus B and divide that by all the folks who didn't have the exposure with C times C plus D, and that will give you a relative risk calculation. We'll do some examples. So here's an example. The risk of stroke and use of long-acting perioperative beta blockers. These were folks who had the stroke, and these are all the folks who didn't have a stroke in this 8,351 subject in the POISE-1 trial. So we can see that the probability of stroke with the beta blocker divided by the probability of stroke with the placebo was 2.16. The 30-day mortality in use of long-acting beta blockers also was very concerning. We saw here the people who died, and some got metoprolol, some didn't, and all the others who didn't die, those with metoprolol and those with the placebo. And doing the arithmetic, the probability of death with the beta blocker here divided by the probability of death with the placebo is going to be 1.33. So more patients, you had a greater relative risk of dying if you were given the beta blocker. So in the second scenario, where we're looking at events that are rare or we don't know the entire population rate, you will look at the probability of an outcome event P1, and that means you're going to look at a certain probability of patients getting some kind of adverse outcome, and dividing that and looking at the probability of patients not having the event. And the odds there are going to be the probability of an event divided by the probability of not having the event. And an odds ratio is just going to be a ratio of those two odds. It's going to be odds of the event with or without the exposure. So an odds ratio is an odds of an event if you get the exposure, whether that be the drug or the treatment, divided by the odds of the event if you don't have the drug or the treatment or the experimental intervention. So just to do the arithmetic here, the same kind of table, got the drug or experimental intervention, yes or no. Here you had the adverse outcome, yes or no. You do the arithmetic and you say the odds of having the exposure versus the odds of not being exposed are going to be A divided by B, and dividing that ratio by C divided by D, cross multiplying, you have A times D, or exposure with the outcome, no exposure, no outcome, divided by the product of no exposure, no outcome, these two cells here. So it's going to be simpler arithmetic. So odds must be used in case control studies since the baseline incidence of the predictor is not known. You're sampling people. The odds ratio tends to overestimate effect sizes compared to relative risks as the frequency of the outcome increases. And we don't have to go through the arithmetic, but I can if you want me to. One study where this was an appropriate question was one which asked what the association was between hypoxemia, airway obstruction in a PACU, and having residual neuromuscular block. That is, patient still has a neuromuscular block that wasn't fully antagonized. They looked for around 42 patients within a period of a year in a large hospital recovery room, and tested neuromuscular function in these folks, and then found a similar number of control patients who didn't have critical respiratory events, and also did neuromuscular testing on them. And this was all done by looking at what we call train of 4 ratio measurements in all of these subjects, all 84, the cases and the controls. And what Murphy and his colleagues found was that these are the people who had normal neuromuscular function. 4 of these folks had critical respiratory events, and the remaining 38 did not. The people who had less than normal neuromuscular function, 38 of these had critical respiratory events, whereas 4 did not. So if you do the cross multiplication, you'll see that 38 times 38 divided by 4 times 4 gives you an odds ratio of 90. So the moral of the story here is that residual neuromuscular block continues to be a major safety problem that that is often not recognized when we wake patients up and take them to the recovery room. So this was a nice way of illustrating that without really knowing the true incidence. So describing relative risk and odds ratio in simple terms, if you have a relative risk or an odds ratio greater than 1, that means that having the predictor condition increases the chance that you will have the outcome. So if the value of a relative risk or an odds ratio is between 1 and 1.99, or between 1 and 2, the risk of your outcome is going to be increased by your relative risk minus 1% or odds ratio minus 1%. And I'll give you an example of that in a minute. For values of 2 or more, the chance is increased by the relative risk or the odds ratio times 1. So examples. If cerebrovascular disease confers an odds ratio of 3.0 of an adverse postoperative cardiac event, what is the increase in the odds? Your odds are going to be 3 times greater of having an MI or cardiac arrest after surgery if you have cerebrovascular disease. Smoking was found to increase your risk of developing lung cancer by a relative risk of 4.8 over a period of time. What is the increase in your risk? You are 4.8 times more likely to develop lung cancer if you are a smoker compared to being a non-smoker. So the language is very slightly different, but relative risk is a little more intuitive. Other examples, if your relative risk of something is 1.25, that means your risk of the outcome is 25% higher. Or if your odds ratio is 0.7, it means your odds of the outcome are actually 30% lower. This is a protective effect. So relative risk, odds ratio, and confidence intervals. The magnitude of the odds ratio and the relative risk indicate the strength of the relationship, but not the precision. The 95% confidence intervals are added to any odds ratio or relative risk to provide an estimate of the precision of that estimate. So, and what it means is that 95% of the time, the actual true value of the population in the entire world is going to fall within your given range. If you have a wide confidence interval, you have less precision of that you can say that that's actually the relative risk, and it's a weaker statement. If you have a narrow confidence interval, this is a more precise statement, a stronger statement. And if the confidence interval crosses 1, we generally say it's not statistically significant. So again, we looked at the stroke risk and perioperative use of long-acting beta blockers. We said that the relative risk was 2.16 of having a stroke. That means, what that means is your perioperative metoprolol conferred a greater than 2-fold increased risk of stroke. That's how you read that. The relative risk of death with beta blockers was 1.33, and we would say that the metoprolol caused a 33% increased risk of death. So a lot of people get confused about how the terminology with these values. So I want to make it very, very clear and easy. So we already kind of talked about this. If both the relative risk and the odds ratio are equal to 1, they have really an equivalent meaning. The probability of the number of events with exposure and the total number of exposure events, and that's probability. The relative risk is the probability with exposure over probability without exposure. Sorry, odds are the ratio of the probability to its complement, 1 minus p. Odds ratios are the odds of an event divided by the odds of no event. At small probabilities, the relative risk and the odds ratio are very close to one another. As the outcome tends to increase in frequency and deviates from what we call unity or 1, the odds ratio increases at a greater rate and thus at certain times can overstate an association. So we have to be a little bit careful and not use odds ratios unless we have to. And so we use relative risk again when we're doing a randomized trial and if the underlying rate of disease is known in the population. You use an odds ratio when it's not possible to measure the entire population at risk. That is, if you have rare sporadic events, and a good example would be finding people who have critical respiratory events in the PACU and determining how many of those had neuromuscular block that wasn't reversed, and then going to other people who don't have a problem and seeing if they have neuromuscular problems. So odds ratio are used in logistic regression also and provide a point estimate of probability of a binary outcome at a given value of a predictor unit. We'll talk about what that means in a few minutes. Multiple logistic regression may be used to adjust for the presence of confounders. Now, I'll tell you in a few minutes what that means, so don't worry. Simple regression models and the relationship between two variables. So regression is essentially looking at one or more variables and looking at their relationship to an outcome. A linear regression looks at a y variable or dependent variable. We also call that an outcome variable, and an independent x variable, and these are both interval values or continuous values. The point estimates in the model are also normally distributed. Don't worry about what that means, but this is typically something we use on normally distributed data. The point estimate gives information about the impact on outcome resulting from each 1 unit increase in predictor variables. So we can express the relationship as an equation, a linear equation where y is equal to an intercept plus some kind of a slope times the the independent variable with the addition of some kind of an error term. Logistic regression is going to be similar, except the independent variable can be binary or continuous, but the outcome variable is always binary. It's always going to be yes or no. So the dependent variable has to be 0 or 1. And this makes this mathematically a little bit more challenging, but we'll talk about how this is done. And what we do essentially is use the log of a proportion to do this, and that's why it's called logistic regression. Here is something in Arabic that I think explains some of this.
Logarit, log, can you go to the last slide for a second?
Sure.
اوكي الترجمه في ترجمه جايه سلايدين linear regression معناها انحدار لان العلاقه بين س و ي العلاقه بين اكس وواي بتتمثل سواء في صوره خط مستقيم سواء في صوره خط منحني والخط المنحني عاده بيتوقف على عاده بنحسب اللوغاريتم لوج LOG يعني لوغاريتم بالعربي طلعوا على السلايد ده منيح حاولوا تفهموا على قدر الامكان and then if we can have the next slide please اوكي قياس الترابط بين المتغيرين في نوعين الانحدار الخطي البسيط والسلايد الجاي الانحدار الانحدار اللوغاريتمي او الانحدار اللوجستي لوغاريتمي او لوجستي هي نفس الكلمه تقريبا يعني وهو اسلوب احصائي يستخدم في قياس العلاقه بين متغيرين على هيئه علاقه داله اللي منكم درسوا تفاضل وتكامل في التوجيهي يعرف يعني ايه الداله اوكي يعني متغير ألف علاقة تغيره بمتغير ب في صورة دالة في صورة معادلة جبرية يعني اوكي فحسيبكم دقيقة او هيك تقروا السلايد ده بتهيألي يعني مفهوم واللي مش فاهم اسأل لو سمحت افتح الميكروفون بتاعك او بتاعك واسأل. So we'll leave this slide on Rachel for about another 30 seconds.
Sure, of course.
Okay, and then if somebody has a question.
Yeah, I have my chat box here. I'm looking at it.
Yeah. Or they can open their microphone and ask a question. Okay, we're coming up about 10 seconds, 10 more seconds maybe.
Yeah, and hopefully that what's coming up is going to help clarify this too.
Oh, absolutely. Now the next slide, okay, you can go ahead and flip to the next slide. That should be the graphic. Oh, that's linear regression.
A little more explanation.
Okay,
so,
go ahead.
Linear regression, the null hypothesis in simple linear regression is that the coefficient or the slope of your line is 0. That's the null hypothesis. So, in other words, stating that there's no effect of the predictor variable on the outcome. It doesn't alter that. It doesn't cause any variation in the outcome variable's value. So, with simple regression, simple means one predictor, one outcome. Multiple linear regression means 2 or more predictors. Each predictor gets a coefficient representing its independent association to the outcome while holding all of the other variables constant. So confounding can be seen when there's a substantial, didn't want to do that. Confounding can be seen when there's a substantial change in the coefficient of the predictor variable when we add other variables to the model. We'll show you that in a minute. But that is one way of recognizing, or that you should suspect, that confounding is taking place. And the doing multiple regression should correct actually for confounding in many cases, not always. So is this the same thing or different? So here's an example of simple linear regression. This is looking at the impact of height on body weight. So it's a continuous predictor, and that is the stature or height, and a continuous outcome predictor, which is weight. What's done is a line is drawn that most closely fits all of the data points that you've measured, and that's how we do. What we do is create what's called a model. And here you can see that an equation can be constructed where y, a weight, some kind of a weight variable, is going to be equal to the intercept here, which is at, I guess at 40 inches, they're saying that people should weigh 80 pounds, plus 2 times the height. So when you make a model and you make a whole bunch of measurements, in this case we're talking about how much is spent on advertising in thousands of dollars and its impact on the amount of money made in the sale of the product that's being advertised. The way that this is all constructed is, first we make all kinds of measurements. You measure a certain product and you say, well, we spent let's say $6,000 on advertising, and we made $110,000 on the product, etc. So what you're doing is you're taking all of these various points and you're putting them on this graph, and then from that a line is drawn with what we call a best fit, where there's the smallest distance of all these points have the smallest distance from this line. So we figure out mathematically how to draw a line where all of these distances are minimal, and we call that fitting a line. In this case, we just looking at this, we can see that we can look at the slope, and we can see that the slope is close to 10. It's actually 9.8. We can see the intercept is about 105.5, and so at a